maybe we can start. We will be conducting this section with Professor Wang. So I will start asking the first question to Professor Jeffrey Lazarus. This is a question from Michael Vettel about, it say your global action agenda identified 29 unique action priorities. If you have to choose 3 that must be focused on first and with the most urgency, what will they be? Or maybe what do you think are the best buy policies on steatotic liver disease?
Well, thank you very much, Luis. Thank you, Michael from Fatty Liver Alliance, for the question. You know, if we have to prioritize, I like to think about change coming from the bottom up, which is many of us in clinics and hospitals, and individual researchers, activists, advocates, and change coming from the top at the same time. But if we had to prioritize, I would actually pick the change from the top. So my first priority would be making sure that MASLD and MASH are on the global NCD agenda. So in the autumn of 2025, there'll be a high-level meeting at the United Nations to discuss the 5 major NCDs, none of which are MASLD and MASH. So I think we need to get on that agenda. We're going to hold a side event at the United Nations this autumn to do that. There'll be a side event at the World Health Assembly again in May this year, but it's incredibly important that the decision makers and policymakers at the highest level address it. At the same time, my 2 other priorities would really be around education and awareness. So the education of our clinical colleagues, so we make sure we have the right models of care, and so that they're also trained to prescribe, whether it's APPs or others aligned with hepatologists. And then the awareness among the patients and those at risk. It's still incredibly low. So that's more of a higher level. Those are the domains, but if you look in the actual actions, there's a number of specific things we can do. Thank you.
Thank you. And the next question goes to Professor Arab. So regarding alcohol biomarkers, so many of them were developed for the identification of alcohol use disorder and perhaps alcohol-associated liver disease. So how about for MetALD? Are they good enough for that range? And if so, do you think some of them are ready for prime time to identify MetALD?
Yeah, it's a great question. I think alcohol biomarkers are useful in the sense that allows you to identify patients that are heavy drinking and they are not reporting. But I think none of them are perfect. The best one that we have is phosphoethylethanol, PEth. PEth is a blood-based biomarker. It's able to identify heavy alcohol consumption or alcohol consumption, even if it's not heavy, up to 4 weeks, so 1 month. In contrast to ethylglucuronide and ethyl sulfate, that are urine-based biomarkers and are only able to identify for maximum 5 days. So I think it's useful. It could be useful, for example, in my opinion, including them in clinical trials, so you can really have a population that is as selected as possible. In clinical practice, if the patient report alcohol consumption, is not only, and is probably one of the problems in the field, is not only the current alcohol consumption. To give you an example, maybe some of the patients were heavy drinking for many years, but then because something happened in their life or they have an intervention, they stopped drinking a year ago. Alcohol biomarkers are going to be negative, but how you classify that patient? So I think is not, I mean, it's not as easy, but we need to consider, and I think the step forward with this nomenclature is recognizing that alcohol and metabolic dysfunction both can produce liver disease, both can have a synergistic effect, and probably when you have a patient with an ultrasound with steatosis, you need to investigate both. I would love to have a biomarker that tells you everything, but I think we are not going to have it, at least not in the short term.
Now, a follow-up question is about the pattern of drinking. So if the amount of alcohol consumption is the same, so what is the current understanding of the effects of binge drinking? So is it worse or it doesn't matter about the pattern?
So we don't have great data, honestly. This comes from population data. We have seen that binge drinking may be worse. This usually happens in younger population, but there is other studies showing that there is no effect. In my mind, binge drinking is worse because you achieve a higher blood ethanol that is probably going to produce higher liver injury, but also you need to model by other things. For example, are you drinking on an empty stomach or with food? That's what some of the prior studies showing that wine was not that bad. But then we realized that actually people that usually drinks wine with food. But people that drink spirits, usually they do it on an empty stomach. So I think we need to have better data, but likely the pattern of alcohol drinking is also relevant.
Perfect. Thank you for your answer. I want to ask a question to Professor Rinella. I know you don't have enough time, but I want to get the opportunity to ask you, what do you think about the implications of the new nomenclature in terms of clinical trials? What can change, or if it will be the same? What do you think about the new implications?
So I think that it really won't have any impact at all. And this has actually been studied in numerous databases, including clinical trial databases, population-based databases. So MASH, the definition is exactly the same. And it's based on the histologic phenotype. We have, of course, biomarkers that we're trying to approximate to achieve that or identify that exact same population, particularly in light of the new drug. But it shouldn't change things at all. The overlap is 98 to 99% of the same population. And I think there was a question also from Yuri Baffy about maybe excessive inclusiveness of the definition, and that was done for two reasons, primarily because we needed to recapitulate the NAFLD population to not invalidate the natural history data that was out there. And then, of course, as we learn more about disease subtypes and phenotypes, we can then weight, or create subgroups of patients. So whether it's, hypertension versus diabetes forward or predominant disease association. So I think that that's where the future will be for that.
Thank you.
Okay, so maybe we'll have another question from Maru first. So first of all, one of the main worry about a name change is whether that would affect the awareness of the disease, particularly outside the field of hepatology. And a related question from the audience is whether there will be a follow-up Delphi process to talk about the impact of the implementation and whether the new proposal has been adopted.
Yeah, that's a great question. So I think it's reasonable to look for adoption, but I would say we should wait several years to do that. The reason being that even with NAFLD, that we've known about it for several decades, the awareness is terribly low, actually, for that. So I think that we need time to get it out there. I do think that the new medications that are being approved, the one that's already approved, will help bolster awareness. And the other thing that I'm hopeful that this will do is by teaching primary care doctors and endocrinologists the underpinnings of the disease and what makes the disease progress forward with respect to additional metabolic risk factors.
I think the connection of Dr. Rinella, it's not the best at this time. So I want to take the opportunity to ask to Professor Lazarus about the question in the chat box about if there is room for translational science or another researchers other than clinical researchers in the MASLD agenda.
Well, it's unfortunate, but good timing for Maru's internet to conk out, because she was just mentioning the importance of understanding progression. And so, of course, we need basic and translational scientists to be looking at a whole range of issues around natural history. Just because we have one drug doesn't mean we don't need more. We have pipelines. We have drugs in the pipeline. There's a lot we still do not understand. This is not like some other liver diseases where we have a much better understanding, like hepatitis C, for example. So, the work that I was presenting was largely from a public clinical and public health and policy perspective, but that doesn't mean that the basic and translational science isn't incredibly important now. So if that's how that came across, that wasn't intended, but we by no means know enough. If we did, we'd have a drug that was as effective as direct-acting antivirals or other more curative drugs or therapies.
Now, apart from pharmacological treatment, of course, another major pillar would be lifestyle intervention. So in the audience, we have a question on food addiction. So maybe we can also talk about eating habits or even eating disorders. So from policies and public health point of view, Jeff, what do you think? What can we do about that?
This is an ongoing issue. And for me, originally, working more with infectious diseases like virohepatitis, it's been fascinating to see the debates that have been going on about what is nutritious food and how do we have proper policies in place to address it. We often associate poor eating with social determinants of health. Those who are poor can't afford healthier foods, but we also in the EASL-Lancet Commission talked about the commercial determinants of health, how targeted marketing to children, how easy access to ultra-processed foods, both in terms of price and location and opening hours, also leads to poor nutrition and overconsumption of low quality foods. So I think it's important for the hepatology community to be thinking, how are we going to do this? How are we going to address food, and who are our allies there? There was an EAT-Lancet Commission on Food years before the EASL-Lancet Liver Commission, and I feel that given that there's NGOs that work with obesity, there's NGOs and CBOs working with food, that's an area that we haven't really created enough allies in, but that we will make big changes through policies versus individual messaging that you should, eat better or have a more healthy diet. It's not that simple when you take structural, commercial, and social determinants of health, as well as awareness. I mean, we're constantly being told X food is healthy for you, and it's not always the case.
And even at an individual level, like for example, we have an steatotic liver disease clinic, and many of us as hepatologists, has been trained on obesity medicine or addiction medicine as and adapt to our training. And I think this is very useful now, where both have a component where behavior and behavioral interventions can be useful, because the same intervention that you can do for alcohol, you can do also for food. So actually, for example, now in our SLD clinic, we have a behavioral specialist that help us with this patient on how to implement lifestyle intervention, which is not easy. I mean, it's not just saying the patient, you need to stop drinking or you need to eat healthier. We know that those things doesn't work, right? We need to actually be trained on brief intervention, motivational interviewing, and ideally on some behavioral interventions.
Yes, very well said. So, and now I'd like to read two comments from the participants before maybe Dr. Diaz asks the next question. So the first comment is by Dr. Michael Battle, so highlighting the importance of international collaboration. So there are indeed many, many questions that we should work together to answer. So I think MetAOD is something new, and the natural history, the best management, all those would be important to work on. And also, when we have the first round, there are indeed many new unanswered questions that we must address. So above all, I think one important thing is how to define non-response. So now I would emphasize that the opposite of response is not non-response. So imagine, so in clinical trials, you must have loss of hepatocyte ballooning and also lobular inflammation declining to 0 or 1 before you say that there is MASH resolution. However, a patient without MASH resolution doesn't mean that she's not responding. So there can be marked improvement in inflammation and ballooning, and yet not fulfilling the definition of MASH resolution. So I think these are the things that we must address. So Professor Elizabeth Brunt also highlighted the importance of considering liver biopsy. So specifically for the evaluation of alcohol-related liver disease, so there are changes that would occur in severe ALD that are not seen in regular MASH without the concomitant alcohol intake. So specifically, sclerosing hyaline necrosis, acute cholestasis, and acute inflammation surrounding the ballooned hepatocytes would be seen in patients with alcohol consumption. So Dr. Dias, maybe you can moderate the next question.
Yes. The next question is about the enhanced data about the low prevalence of ALD. So I want to ask to JP, what do you think about this low prevalence? It's real, or maybe there are some biases on those studies?
Yeah, it's a difficult question. And again, we go to the problem that how we quantify alcohol consumption, right? So it is NHANES will ask for current alcohol consumption. And so it's not capturing the historical alcohol consumption data. And then probably there is a significant amount of underreporting. I don't know whether also the thresholds that we use for defining are too high if we consider that most of those studies were trying to look for cirrhosis, right? Chronic liver disease or the threshold of alcohol for chronic liver disease. Chronic liver disease was defined as cirrhosis. And here we are early in the disease process. We are talking about steatosis or steatohepatitis. So probably ALD is higher than what is there. If you consider that 6% of the population has an alcohol use disorder, globally in the Americas, it's close to 12. Probably you will expect a number closer to 10%, more than 1%. But still, I mean, we will need like more quality data in the future to be able to better gauge how much ALD we have.
Thank you, JP, and thanks to all the speakers. I think we are on time to move to the next sections, and thanks